Did you know that the so-called gold standard of 120/80 could actually be a hidden danger, leading millions of people to be overtreated without even realizing it? My name is Ethan Marshall. I'm a 60-year-old cardiologist here in the United States, and what I'm about to say may surprise you, that familiar 120/80. The number so many people believe is the gold standard for blood pressure isn't always right for everyone. If your doctor has ever told you to get your blood pressure exactly to that point, pause for a moment and think, does it really make sense that the entire world should be squeezed into the same mold, regardless of age, body type, or lifestyle? Before we dive deeper, I'd like to invite you to subscribe to this channel, hit the like button, and share this video so we can continue bringing you honest, high-quality health information that truly matters. So first, let's get clear on what blood pressure actually is. It's the force of blood pushing against the walls of your arteries as your heart pumps and rests. There are two numbers that always come with blood pressure readings. The top number, called systolic pressure, reflects the force when your heart contracts, while the bottom number, diastolic pressure, reflects the pressure when your heart relaxes. Most people focus more on the top number since it's higher, but both numbers carry real clinical meaning. If the systolic is high, the diastolic usually rises too, and vice versa. Doctors have debated for years about which number matters more, but what few will tell you is this. The real importance lies in how your body responds, not just in the number you see on the screen. So why has 120/80 been considered the gold standard? For decades, it's been treated as a safe reference point because people who fell into that range generally had fewer heart-related problems. But it was always meant as a guideline, not a rigid rule. Think about this. Would you expect a healthy 30-year-old and an 85-year-old woman with stiffened arteries to both maintain the same blood pressure target? For older adults, natural aging and vascular stiffening make it potentially more dangerous to force blood pressure down to 120/80 than to allow it to run a little higher. On the other hand, for a younger person who's overweight and insulin resistant, 120/80 might not be safe enough. The takeaway here is simple. The so-called standard is just a starting point, not a universal finish line. When you visit your doctor, remember that 120/80 should be seen as a reference, not a sentence that everyone must follow. Human beings don't operate like identical machines, and forcing hundreds of millions of patients into one rigid target has been one of modern medicine's biggest mistakes. And now let me leave you with a question to reflect on. If your doctor tells you that you must keep your blood pressure exactly at 120/80, would you A, trust completely and follow without question, or B, step back, ask questions, and listen to what your own body really needs? Share your answer in the comments below. I'd love to know if you choose A or B. Rigidly applying the 120/80 blood pressure standard to everyone has revealed major limitations and potential risks, especially when considering the diversity of age, body condition, and underlying health issues. In older adults, the vascular system has often undergone stiffening and lost elasticity, and forcing blood pressure down to a level suitable for a younger person can result in excessive drops causing dizziness, falls, and reduced blood flow to the brain, all of which increase the risk of cognitive decline or stroke. At the same time, reduced blood flow to the kidneys under these conditions can further impair kidney function, which naturally declines with age. Recent clinical studies have shown that in patients over 80, systolic blood pressure maintained between 140 and 150 mmHg can actually be associated with higher survival rates compared to those pushed down below 120 mmHg, almost highlighting that there is no single ideal number that works for everyone. In addition, discrepancies in blood pressure readings are common in practice, such as white coat hypertension, where readings are elevated in the clinic due to anxiety, or masked hypertension, where readings look normal in a medical setting but rise at home. These phenomena show that a single measurement taken in either a stressful or relaxed moment cannot reliably reflect a patient's true vascular health. Yet treatment plans are often built around these one-time numbers. Compounding this issue, the modern medical trend has been the lower the better, a mindset reinforced by strict clinical guidelines, but not always suited to each individual's reality. In some cases, pushing blood pressure too low exposes patients to complications that may be more dangerous than maintaining a moderately higher but stable level. This reality calls for a critical reevaluation of how blood pressure standards are set and applied. Instead of enforcing a uniform benchmark for all medicine, must move toward flexibility and individualized targets to ensure both effective treatment and patient safety in every unique context. One of the most common realities in treating high blood pressure today is that patients are often started on medication fairly early, sometimes as early as their 40s or 50s, and their treatment plans tend to escalate over the years, with increased dosages or added drugs, while adjustments to reduce or discontinue medication are rarely made even when health conditions improve. This practice leads to polypharmacy, where patients must take multiple blood pressure medications at the same time, in some cases 3 or 4 different drugs. As the number of medications grows, so does the risk of side effects, and the results are often excessive drops in blood pressure, dizziness, lightheadedness, reduced mobility, and a significant decline in quality of life. The danger extends beyond these immediate symptoms, as it also increases the risk of falls, cognitive decline, and higher hospitalization rates in older adults. A typical clinical example involves patients who, after losing weight or improving their diet, continue on their previous dosage, resulting in blood pressure dropping to an inappropriately low level and leading to transient cerebral ischemia and related complications. This situation reveals a fundamental weakness in current treatment management, where too much emphasis is placed on numerical readings of blood pressure, rather than a comprehensive assessment of the patient's overall condition. Clinical guidelines often impose rigid frameworks binding doctors to maintain target numbers instead of considering individualized approaches. The consequence is that many patients end up being overtreated despite their actual physical needs being different. In this context, the lack of regular reviews of medication regimens and the failure to reevaluate after changes in weight, lifestyle, or other health factors inadvertently create a heavy burden on patients. Additionally, there is a widespread over-reliance on prescriptions treating medication as the sole solution, instead of integrating non-drug interventions such as improved nutrition, regular exercise, or stress management. Taken together, these patterns illustrate a central problem in modern medicine. The system continues to operate under a numbers-driven mindset, relying on single-office readings as the primary determinant of treatment decisions, rather than placing the patient at the center with all their physiological changes, age-related factors, and life circumstances. As a result, many patients not only suffer the side effects of overtreatment, but also fail to achieve the level of health and well-being they truly need. Therefore, re-examining the treatment model with a focus on flexibility and regular reassessment is essential to minimize errors and ensure more effective long-term care. The solution to today's challenges in hypertension management lies in personalization, setting blood pressure goals tailored to each patient's unique profile, including age, vascular condition, coexisting diseases, and the body's own responses. Research has consistently shown that for elderly patients, particularly those over 85, maintaining systolic pressure around 150/90 mmHg can be perfectly acceptable if no dangerous symptoms are present and no serious comorbidities exist. This clearly demonstrates that applying one rigid number for everyone is neither practical nor safe. Instead, what is needed is a flexible, individualized threshold for each case. Alongside treatment goals, home monitoring plays a critical role in ensuring accuracy and objectivity. Arm cuff devices should be prioritized over wrist cuffs because of their greater reliability, and patients are advised to measure their blood pressure in the morning and evening, taking 3 readings each time and averaging the results. This process should be continued for at least 2 weeks, with results carefully recorded and compared against clinical measurements. Such dual monitoring not only eliminates the distortions caused by psychological stress in a clinical setting, but also provides physicians with a fuller, more accurate picture before making decisions about medication adjustments. In addition to individualized targets and improved monitoring lifestyle modification forms, the foundation of hypertension management, a healthy diet, adequate sleep, regular physical activity of 20-30 minutes per day, and effective stress management have all been proven to improve blood pressure control. Among younger adults, insulin resistance is considered the main driver of hypertension, with studies showing that more than 50% of patients under 50 with high blood pressure also present with impaired glucose metabolism. Addressing this through dietary changes and consistent exercise is critical, as it allows blood pressure to stabilize without relying solely on medication. An important perspective is offered in Arnold Ehret's Rational Fasting, often translated as Mucusless Diet Healing System, or Eat to Heal, which adds a philosophical dimension to medical science. Ehret argued that much of chronic disease, including hypertension, stems from the accumulation of mucus, a byproduct of consuming excessive processed foods, refined starches, and animal products. As blood becomes burdened and less clean, arterial pressure rises, setting the stage for hypertension and other conditions. His proposed solution is gradual reduction of industrial foods, replacing them with fresh fruits, vegetables, and natural produce, thereby restoring the body's innate capacity to self-regulate and rejuvenate circulation. When integrated with evidence-based medicine, this approach not only reduces dependence on drugs, but also opens a long-term path to stable blood pressure and more comprehensive health and vitality. This synergy between modern clinical practice and natural healing philosophy highlights that the true future of blood pressure care is not rigid adherence to universal numbers, but an adaptive, personalized strategy that respects both science and the body's inherent wisdom. Looking back at all the discussions and evidence, it becomes clear that ideal blood pressure is not always the widely cited 120/80 number in modern medicine, but rather the level that allows the body to stay healthy, alert, and free of dangerous symptoms. What matters is not hitting an absolute figure, but ensuring that the brain, heart, kidneys, and other vital organs receive sufficient blood flow to function normally. Many patients believe that pushing blood pressure as low as possible is best, yet in reality, when blood pressure drops too far, dizziness, fainting, memory problems, and falls can occur, leading to a serious decline in quality of life. That is why each individual must be guided by a personalized approach where targets are set according to age, physical condition, comorbidities, and unique physiological responses. Patients should also be encouraged to take an active role in treatment by speaking openly with their doctors about continuing or reducing medications and asking important questions such as, "Do I really need this many drugs, or is this number truly right for my body?" Empowering patients in this way is one of modern medicine's key steps to limiting overtreatment and reducing the burden of unnecessary prescriptions. The core message is that health cannot be measured by a single number. It is the sum of safety, mental clarity, and the ability to live everyday life normally. Personalized treatment rather than rigid guideline-based care can reduce side effects, lower dependence on medications, and allow patients to maintain their natural balance. On this foundation, a sustainable solution is not about relentlessly chasing lower blood pressure, but about combining modern medicine with lifestyle interventions, balanced nutrition, appropriate exercise quality, sleep stress management, and as Arnold Ehret emphasized in Eat to Heal, gradually removing processed foods so the blood becomes clean again, the circulatory system is relieved, and the body has the chance to restore itself. Only with such a strategy can people move closer to the goal of living healthier, with fewer illnesses and less reliance on medication. Ultimately, optimal blood pressure is not one fixed value for everyone, but a safe range unique to each person. The essential task is to listen to your body, work with your doctor, to set the right target, and persist in making positive lifestyle changes to achieve better and more sustainable quality of life. And now I'd like to hear from you. What do you think is the most important factor in controlling blood pressure? A sticking strictly to prescribed medication, or B, building lasting lifestyle changes? Please share your choice in the comments below. If you'd like more in-depth resources, fill out the form in the description to receive a free ebook on healing health. Don't forget to subscribe, hit the like button, and share this video to support us in bringing you even more valuable content in the future.